Hello.
Hi, how you doing?
Hey. Good, good. Sorry, my WhatsApp is just not working for
Oh,
some
no
reason.
worries. This is
Um,
probably
but yeah, with the polls, will they just come up on the screen or
Do you have a button for it along the bottom?
no, there's only a Q&A one.
Okay, that's fine. I
Yeah.
think I can start them for you. So you'll go through like all of your questions and give the students like a minute to answer them,
Yeah.
like, with a pen and paper. And then when you go through each answer, I'll bring up a poll for each question, and then they can
Okay.
answer the poll, and then you'll know kind of the vibe of what their answers were when you're actually going through the explanation. Does
Yeah,
that make sense?
yeah, that's fine. And do I need to share my video? Because I think I don't have access to it. Says
No worries if you
I've not given permission.
can't share your video, that's fine, but you can share your slides, right?
I'll just double check. I might as well just open it up now.
Okay. Oh, it's gone.
Oh, have we lost him?
Yeah, I think so. Oh dear.
Good start.
I wonder if I can just get his slides up.
Yeah, that potentially may be easier.
Find them.
Oh, he's back.
Oh,
Sorry, I just had to give access to share screen and it asked me to restart. Let me know when you can see that.
Yeah, that's the one.
great.
Perfect. Yeah, you can also see that, right?
Yeah.
Yeah, that's all good.
Yeah.
I'll leave it till about 5 past and then we can get started. That sound okay?
Yeah, sounds good.
Hi everyone that's joining. We'll be getting started in a few minutes. Just let everyone join on the Zoom link. So sit tight, but we'll be with you in a few.
Katie,
Yeah,
can you enable the chat?
yeah, sure.
You mind doing that? Because we've got one question just asking about the feedback form.
Okay.
And I thought I have answered it, and the link is in the answers if anyone wants to
Okay.
use the feedback form early if they need to leave early or anything like that. But I'll also put it in the chat so people can have access to it.
Do you know how to enable the chat?
No.
No. No, is it definitely not working right now?
I can send you a message, and that's about it.
Okay. Panelists can chat with everyone, and then attendees can chat with this. Does that work?
Everyone, perfect. Thank you. Hi, everyone. So just a couple of minutes again before we kick off, just in the interim, if anyone has any questions about anything during the session or prior to the session, just drop them in the Q&A or feel free to give us a direct message and we're happy to answer throughout the thing.
Hi everyone, welcome to tonight's Thursday 15 talk. It will be all about paediatrics, and Dr. Menon from the Royal Liverpool Hospital will be delivering tonight's talk. As usual, we'll go through the 15 MCQs at the start as a mock exam, so make sure you've got like a pen and paper to hand, and then we'll spend the rest of the session going through the questions and the answers and some explanations in a more interactive way. I've enabled the chat for tonight's session, so feel free to pop anything in there. We really encourage you to be interactive with it if you want, and then anything that you want answering directly or with a more full answer, pop it in the Q&A and I'll try and reply to you throughout the session. But I'll hand over to Gaurav now to give your session for tonight. Are you still there? Yeah, good.
Yeah, thanks for that, Katie. Thanks for introducing me. I'm Gaurav. I'm one of the F1s at Royal Liverpool and going through cardio resp in pediatrics specifically. It's quite a dense topic, but we'll try and get through it in an hour. So we'll get cracking with the questions. So 1 minute per question as we normally do. And I'll start the timer now. Move on to the next question. Question number 3 now. On to the next one. Question 5. Question 6. To the 7th question. About halfway through now. On to question 9. To the next question. Just the last few questions now. And to question 12. Question 13 now, almost there. So last couple of questions now. On to the final question. And that's all the questions. So what we're going to do now is go through the questions again, and the poll will come up where you can answer the questions, and then we'll go through the answers and do a little bit of teaching around the questions. Some questions are combined and they have teaching topics combined with the questions. So we'll go to the first question now, and the poll should come up now.
Hopefully, yeah.
Okay, so I see most of you have gone for B, which is the correct answer. So this question is around the topic of stridor and croup. So croup is one of the most common respiratory conditions that you'll come across, especially in exams. It is caused by acute airway obstruction of the upper airways, which cause stridor. And the typical organism that causes it is parainfluenza virus. There are other organisms that cause it, such as RSV, but parainfluenza virus is the most common. It typically affects a wide age group from 6 months to 6 years. With it, you do get coryzal symptoms, fever, hoarseness of the voice. You get a typical barking cough. In exams, they may explicitly say barking cough, or they may describe it as a barking cough. And you do get increased work of breathing. On the image on the right-hand side, you just see different signs of respiratory distress. So nasal flaring, tracheal tug, recession of the intercostal, subcostal, and substernal muscles. In terms of the management, generally use steroids for it. The go-to option is usually dexamethasone, where you use 150 micrograms per kilogram. Sorry about that. And if it is severe, you would try some nebulized adrenaline to help relieve the inflammation and the obstruction. So on to question 2. Can answer that on the poll. So most of you have gone for option B, which is the correct answer in this case as well. So this is another cause of stridor, but it's a much less common cause because of the vaccination program. So this is epiglottitis, which is the inflammation of the epiglottis and all the tissue that's surrounding it. And the reason why it's less common is because it's caused by Haemophilus influenzae type B, and that it's one of the organisms that you are vaccinated against. It is a life-threatening emergency where you'd have to really look after the airway, and they do recommend that if you are thinking along the lines of epiglottitis, you don't examine the airway because it can cause obstruction. To investigate this further, you would do a lateral x-ray of the neck, and you see the sign called thumb printing, where you which is shown on the right hand side. It looks like an area the size of a thumb, and it's caused by the shadowing due to the inflammation of the epiglottis. This table on the right is just taken from one of the textbooks I used in medical school. It's called Illustrated Textbook of Pediatrics, in case you want to use it. It shows the differences in presentation between croup and epiglottitis. It would be quite important because epiglottitis would present much more acutely than croup does, and it can be much more severe than croup is. Going on to the third question. Okay, so this question has a bit of split between option A and E, where most of you went for option A. The correct answer is option E. So this is because of the NICE guidelines referral criteria for bronchiolitis, which I'll go through. So bronchiolitis is the most common cause for a wheeze in infants, and you see it from the age range of 1 to 9. The most common organism that causes it is respiratory syncytial virus. I don't know if I pronounced that correctly, but the clinical features you normally get are coryzal symptoms initially, then you get a wheeze and a cough. You can get shortness of breath, and on examination, you get fine end inspiratory crackles and a high-pitched wheeze. So coming on to the answer for this question, there are certain indications for immediate hospital admission, and some where they do suggest hospital admission if you do see this in GP. So the main ones to look out for are apnea. The apnea is either where you observe it when the child presents, or even if it's reported by the parents while they're at home, that is a red flag criteria to send them straight to hospital. If the child looks unwell, to a medical practitioner, send them to hospital straight away. Any signs of respiratory distress, so if their respiratory rate is above 60, you'd consider hospital admission, and if it's above 70, you'd immediately send them. This question, the reason why they would send the child to hospital is because they had low fluid and oral intake, which is the fourth criteria on this list. Then if you see that they're dehydrated or their SATs are persistently below 92% on room air, you'd think about hospital admission. If you're interested, you could have a read on NICE guidelines on the full list of criteria. This is just a summary. But all of you, or most of you, were correct, and you would manage it supportively with humidified oxygen. There are special cases where you'd give palivizumab, which is an IM injection, and it's used as prophylaxis for high-risk patients. Some of these include Down syndrome and bronchopulmonary dysplasia. And the main complication to think about is bronchiolitis obliterans, which is due to bronchiolitis, and you get irreversible damage to the airways. On to the fourth one now. Okay, another question. This is about asthma management, and see, most of you went for B. The correct answer in this case is actually A. It was quite a confusing question because the management depends on age. So if you're under 5 years old, the management would change if you were 5 to 16 years old. So we'll just go through the asthma chronic management and the stepwise approach according to NICE guidelines. So in a patient who's under 5, you generally start with a SABA, so salbutamol. If that's not tolerated, you try moderate dose ICS for 8 weeks. You see if the symptoms resolve, and you stop the ICS regardless of whether the symptoms resolve or not. So, and then after 8 weeks, you monitor them again. If the symptoms return within 4 weeks, you start a low dose ICS. And if the symptoms resolve, but if they resolve after 4 weeks, you repeat the 8-week trial of moderate dose ICS. And if the symptoms didn't resolve with the moderate dose ICS, you'd think about alternative diagnoses. After this trial, and after you start the low dose ICS, if they're still having trouble controlling the asthma, you add on a leukotriene receptor antagonist, so montelukast. And if that's still not working, you stop that and refer to a specialist. It changes when you are older than the age of 5. So you start with SABA, and then you go to a low dose ICS. You don't need to do that 8-week trial. And then you add montelukast, still not controlled. You stop the montelukast, add on a LABA. Then after that, you change to MART, which is basically a combined inhaler where you get a LABA plus an ICS, and it's usually immediate acting. If that doesn't work, you change the low dose ICS to moderate dose, and then after that, you'd consider speaking to a specialist. So the main differences here are starting the ICS, whether it's moderate dose or low dose, and that depends on the age. And the reason for that is mainly because below the age of 5, it is quite difficult to diagnose asthma. So they want to be completely sure that that is the correct diagnosis. On to the 5th question now. Yep. So this question's about acute asthma management, and the correct answer, as most of you put down, is A, which is oral prednisolone or IV hydrocortisone. Looking at acute asthma management, it's important to assess it correctly and then manage it correctly. So these are just some images I took from this app called Foundation. So when you start F1, it's a really useful app if you want to get it. So when assessing acute asthma, as you can see on the table on the left, you look at the different features which you'd see on assessment and examination. It's important to note that as long as there's one feature from any of the criteria, then they would fall under that criteria. So for example, if the peak flow is like 75% and the SATs are 95%, but they have a silent chest, you'd still put them under life-threatening. And then the management of asthma. So first you give them oxygen, then you give them nebulized salbutamol and ipratropium. Then after that, you'd go to steroids, which is what the question was assessing. So you go for prednisolone or hydrocortisone. After that, you consider magnesium sulfate. At this point, you'd also consider speaking to your senior. They could consider aminophylline, they could consider ITU. But as long as you get the basics right from the beginning, give the nebulizer, give the steroids, you'll be fine. Question 6. Yeah, most of you have gone for option C, which is the correct answer in this case. So this is about cystic fibrosis, which is autosomal recessive disorder, and it affects a gene called the CFTR gene that's involved in the chloride transport. So I know a few people put the newborn blood spot test as the gold standard investigation. So that would be the correct answer in most individuals. But in this question, it was an individual born outside the UK and who does not have a diagnosis of cystic fibrosis. So they wouldn't have had the newborn blood spot test. So it would generally present when you are first born and you have the heel prick test. Sometimes it does present with meconium ileus, where the newborn doesn't pass meconium for the first 24 hours. Or it may present later in life as well, where you get recurrent lower respiratory tract infections, failure to thrive, may get pancreatitis as well. So as we said in the question, the gold standard is the sweat test. You can get, if you're still unsure about the diagnosis, you could do genetic testing as well. Use MDT approach for management in that the doctors can prescribe medications, use dietitians, you need a high calorie diet, do chest physio, and along those lines. Key complications are opportunistic infections. So I just find it quite interesting how you wouldn't bring a group of children with cystic fibrosis together because they can spread infections and get really unwell. And a key infection to think about is Pseudomonas. On to question 7 now. Okay, so most of you have gone for option E, which is correct in this case. So this question's about bronchopulmonary dysplasia, which is also called chronic lung disease of the prematurity. And what this is a condition that affects premature babies who are usually born before 28 weeks gestation. And these babies normally require oxygen after they're born, or ventilation and intubation. When they require this for a long time after birth, even after they are off it, they'll still get persistently low oxygen saturations, increased work of breathing, failure to thrive. Their lungs don't sound great on auscultation. You get crackles, wheezes. They have increased susceptibility to infections. You do see chest X-ray changes, as you can see on the right, after 36 weeks gestation. So if you get a premature baby, if you are thinking this, you don't really see chest X-ray changes immediately. You'd only see it after a week or so after they're born. There are ways to prevent this in premature babies. So you'd give the mother steroids to help with the maturation of the lungs of the newborn. And then you could think about non-invasive ventilation after the child is born, and avoid over-oxygenating them if this is needed. And on to question 8, which is where we go more onto the cardio questions rather than rest. Okay, and all of you have gone for option B, which is the correct answer. There's just one more question before we do a teaching slide. So on to question 9. And most of you have gone for option C, which is the correct answer in this case as well. So just going a little bit about fetal circulation, I think this is quite an important topic because the circulation in a fetus is different to that of a newborn. So the reason is because the fetus's lungs are not fully developed, so it can't transport oxygen across the whole body. Therefore, it needs to get nutrients and everything from the mother through the placenta. The question looked at 2 key differences, which is the ductus arteriosus and the foramen ovale. So ductus arteriosus is between the pulmonary artery and the aorta, and the foramen ovale is between the atrial septum. There is also ductus venosus, which connects the umbilical vein and the inferior vena cava. So this is what it is before birth, to allow the mixing of blood, so that the fetus essentially gets more oxygen. After birth, this changes because the newborn takes the first breath. This expands alveoli, and it decreases pulmonary vascular resistance. The right arterial pressure reduces, and that closes the foramen ovale. The increase in blood oxygen also decreases prostaglandins, which closes the ductus arteriosus, which is why in the previous question you'd give prostaglandin to keep it open to allow the mixing of blood. And then when you clamp the umbilical cord, it closes the ductus venosus. Question 10 now. And as the majority of you have put, option B is the correct answer. So ventricular, there's another slide before we go through the teaching slide now. And for this question, Eisenmenger syndrome is also the correct answer, as most of you have put. So ventricular septal defect is one of the heart defects that you do see congenitally. It does vary in size, and the symptoms can vary depending on the size of the ventricular septal defect. So as the name suggests, it's a hole between the two ventricles. It's associated with Down syndrome and Turner syndrome. It's a left to right shunt, so blood can leak from the left ventricle to the right ventricle. And because the blood is already oxygenated on the left ventricle, it's an acyanotic heart defect. If it's small, it is usually asymptomatic. You can hear a pansystolic murmur, or sometimes in books it's referred to as a holosystolic murmur on the lower left sternal edge. If it is small, especially, the defect can close spontaneously. However, if you are concerned, it can be closed surgically. I think they usually use an open heart approach to treat this. A major complication to know about, like in the previous question, is Eisenmenger syndrome. So it usually presents in the late teens, early adulthood, where you have a ventricular septal defect, and because a lot of blood is leaking from the left side to the right side, it causes right-sided overload, which then causes right heart failure, and that increases the pressure in the right side of the heart. This causes the shunt to reverse, so the deoxygenated blood from the right side start leaking onto the left side, and this leads to a cyanotic heart defect rather than a acyanotic, which it was previously. To the next question now. Okay, so most of you have gone for D, which is the correct answer in this case as well. So this question is about tetralogy of Fallow, which is tetralogy means four, and Fallow is just the name of the syndrome. Probably the person who identified it, or the first person that suffered it. I'm not really sure. But so the reason is four is because there are four different defects that you see. So one of them is a ventricular septal defect, which you have gone through. One is the overriding of the aorta. So what that means is the aorta sits a little more to the right than it is usually. And the implication of that is because it's more towards the right, some deoxygenated blood goes into the aorta and to the rest of the body, causing cyanosis. With it, you also see right ventricular hypertrophy, and you see pulmonary stenosis, which can cause right heart failure. It is usually picked up antenatally. So in the UK especially, they do a lot of antenatal checks and scans. So while the baby is still in the mother, you can pick it up. After they're born, you can see cyanosis, you can see ejection systolic murmur. If it's diagnosed late, you may see clubbing, failure to thrive, and you see these things called TET spells. TET spells are just what they are episodes of cyanosis, which are seen in different cases, especially when the child is crying or when they're running around and playing. You do see it commonly that the child will change their position to help more oxygen get around the body. So in an older child, you may see them squat to help relieve this. And in a younger child, you may see them bring their knees up to their chest. Investigations, you can use an echo to diagnose it, to look at the heart. When you do a chest x-ray, you may also see a boot-shaped heart, and this is mainly due to the right ventricular hypertrophy. I said before that on auscultation, you get ejection systolic murmur. That's usually due to the pulmonary stenosis. And the management is initially as a newborn, when they first present, give them prostaglandin to keep the ductus arteriosus open to allow the mixing of the blood. And you do that while you wait for surgical repair, which is basically the only way that you can fix this problem. And on to the next question. Okay, there's a little bit of a split here between E and C, where most of you have gone for E, which is the correct answer. So this question looks at coarctation of the aorta, which is the narrowing of the aortic arch, and it's commonly seen with Turner syndrome. There are two main types of coarctation. One which is preductal, which is what we saw in this question. So preductal is where the coarctation occurs before the ductus arteriosus. And postductal is where it occurs after the ductus arteriosus, and that usually presents as an adult. What normally happens is it presents with higher oxygen saturation and blood pressure in the upper extremities. So the reason this happens is because the narrowing or the coarctation happens after the vessels that supply the upper extremities, which is why maybe in your obs and gynae placements or your pediatric placements, you may have seen the nurses and the midwives doing the blood pressure and oxygen saturations in both the upper limbs and the lower limbs to look for this. You also do see a weak or absent femoral pulse, and they normally present 2 days after birth where they get unwell really quickly, and this is due to the closure of the ductus arteriosus. So management, again, similar to tetralogy of Fallot and most other cyanotic heart defects, where you give them prostaglandin while you await surgery. To question 14 now. Yeah. Yes, so the correct answer for this question is A, group A streptococcus. And just going through rheumatic fever quickly. Rheumatic fever is an autoimmune condition, that's triggered by infections, particularly group A streptococcus, as we just mentioned. So it presents 2 to 4 weeks after streptococcal infection. The most common one you'd see is a patient who has strep throat, treated for that a couple of weeks later, has a presentation that fits with rheumatic fever. So you do see various different signs that point towards rheumatic fever. And it is like a lot of rheumatological conditions where you get a lot of different signs and symptoms all over the body. So you get a fever, you get joint pain, and this is called a migratory arthritis. The reason it's called a migratory arthritis is because you get joint pain in different joints that present randomly and self-resolve. So it looks like it's going from one joint to the other. You get 2 types of rashes. You get subcutaneous nodules and erythema marginatum, which are like circular pink rashes. You get neurological signs. So you get syndonyms chorea, which is involuntary muscle jerks, which are seen, and you do get some cardiovascular signs such as carditis. On the right side, you see the diagnostic criteria. So there's a major criteria, minor criteria. There are different mnemonics to help memorize this, but essentially, the first thing that you need is evidence of a streptococcal infection. And then after that, if you have either any two major criteria or one major criteria and 2 minor criteria, you can diagnose rheumatic fever. You'd manage this mostly symptomatically. So NSAIDs for arthritis, and creams and things for the rash, paracetamol for the fever. And the main complication is recurrence of the acute phase of the rheumatic fever. You can get valvular defects such as mitral stenosis, and you can get heart failure with it. And on to the last question now. And most of you are correct with this one. It is option D, coronary artery aneurysms, which is an important complication of Kawasaki disease. Just have a few more minutes. I'll quickly go through Kawasaki disease. It is a medium vessel vasculitis. And it's a clinical diagnosis where you get a lot of these random symptoms, like I said, with a lot of rheumatological conditions. The main thing is a prolonged fever of more than 5 days. And then you get other things with it, such as a strawberry tongue, red cracked lips, conjunctivitis, peeling of the hands and the feet with redness, and you may get a rash as well. Once you have these symptoms, you could diagnose it clinically, but you can use other investigations to help with the diagnosis. So in terms of blood tests, if you do a full blood count, you'll see anemia, leukocytosis, thrombocytosis. You may see elevated liver enzymes and elevated inflammatory markers as well. Urinalysis could help, and an echo is important to rule out coronary artery aneurysms. Management is high-dose aspirin for preventing thrombosis, and IV immunoglobulins help prevent coronary artery aneurysms. And we said the key complication are those aneurysms. And that's the end of the presentation. It would be really helpful if you guys give feedback, and once you fill in the feedback form, we can send you the slides as well. So if you could just scan this QR code, that would be really helpful.
Thanks so much, Gaurav. That was a really great talk. Just a reminder to everyone that's still online, these sessions run weekly and you can find the Zoom link for each one on our Facebook page. Don't forget to fill out the feedback link before you go, because that's what will give you access to the slides and the recording from the session. Feel free to pop any questions you might have in the Q&A. I think we've got one about cardiac aneurysms for Kawasaki's. I don't know if you know, Gaurav, how long after presentation can these aneurysms form?
So they normally form in the first few weeks of presentation. And just the second part of the question about how long you'd monitor it, I would think you monitor it at the beginning and you don't continue monitoring it. But I will be honest, I'm not 100% sure about that. But it's usually in the first 2 to 4 weeks of presentation where you get these aneurysms, and then after that the symptoms settle, and I don't think you generally continue monitoring for it after that.
Great. If no one else has any questions, we can close the session there. But thanks everyone so much for coming.
Thank you, everyone, and hope you enjoy the rest of your evening.
Thank you, Gaurav. That was really good.
Yeah, it was great.
All right, thanks, guys.
Thanks.
Hope you enjoy the rest of your evening.
You too. See you later.
Bye.
Yeah, sorry. Thanks again, mate.
That's
Really good lecture. Yeah, have a nice rest of your evening as well. We'll speak to you guys in a bit. Thanks.
All right, see you. Bye.
Bye.